too much detail about this, just because some of these frameworks are quite comprehensive and complex, but I just wanted to share an example of some of these with you. So the first here on the left is a framework which was developed by Dr. Matthew Menier and others, and it really shows kind of the key features that should be included in a learning health system, as well as some of the key outcomes or outputs from a learning health system. In the middle, from the Learning Healthcare Project, this is a model which really shows that in the middle, you have that core learning health system example where you're bringing knowledge and data into practice. And then it describes some of the strategies and components that should be taken into consideration if you're aiming to implement a learning health system in practice. And then third here by Endicott and others, this is an Australian group who developed this learning health system framework, and they talk about these sort of 4 key components of where you should bring evidence into the learning health system. And so there's been some work done around trying to understand what are the key features of a learning health system and what should that look like. So Friedman was a researcher who's done a lot of work in the learning health system space. And he suggested in 2016 that there should be 5 key features as part of a learning health system. So the first is that a learning health system should be patient focused and have patient experience available as sources of data. A learning health system should use best practice knowledge, which is derived from data, and this should be immediately or rapidly available to support healthcare change. Third, a learning health system should be this continuous improvement process. Fourth, a learning health system should have the infrastructure that enables this immediate inclusion of data into practice. And then fifth, there should be key stakeholders within the system who see this idea of learning health system as part of their culture. And similarly, in 2018, another researcher, John Lavis, created this list of 4 core components, which align with 7 key characteristics that should be part of a learning health system. So in his approach, he described that a learning health system should be data and evidence driven. So this can include having digital capture, linkage, and timely sharing of data, as well as timely production of evidence. A learning health system should be patient-centered, so having patients engaged in that research system process. A learning health system should be system supported, so having that governance and financial arrangements, as well as having appropriate decision supports to support a learning health system. And then fourth, the learning health system should be culture and competency enabled, so having a culture of learning and improvement, as well as having competencies for learning and improvement. So as you can see, these two descriptions of sort of the key features of a learning health system are slightly different, but you can see the overlap across these 2 approaches. And it's really just going back to this idea of having patients at the center, having data being driven into informed practice, and having that system and culture to support this work. And so this idea of learning health systems has really gained traction over time. So since 2007, where the Institute of Medicine had their roundtable on evidence-based medicine and came up with that definition that I shared with you in the beginning, there's been some reviews done which explored all of the work happening around learning health systems. So in 2016, Buteronis and others conducted a review where they included 30 studies related to learning health systems, and 13 of these were specifically talking about learning health systems that have been implemented in practice. In 2017, the Learning Health System Journal was established, so we now have a journal which is specifically dedicated to learning health systems research. And then in 2020, Zarinsky and others created a scoping review where they reported on over 200 papers and learning health system studies, which spanned from learning health system frameworks, studies on learning health system features and components, as well as case studies around specific learning health systems that have been trialed in practice. So you can see just how this area of research has grown over time, and it's this review by Zirinsky was conducted in Australia, so you can also see that it's not just here in Canada or the US, it's really around the world. This idea of learning health systems is gaining traction. And so why are people interested in this idea of learning health systems? Well, the main purpose of a learning health system is to achieve what's called value-based healthcare. So putting patients at the front of our healthcare system, trying to improve patient outcomes, but also aiming for better quality care rather than just more healthcare interactions. And also working towards having more efficient healthcare spending. So trying to keep costs low while providing better quality care to patients. And we also know that from the evidence, some of these learning health systems that have been implemented have shown to have improvements in patients' lives. So in one particular learning health system, they found that after they implemented their learning health system, there was a reduced length of stay, there was fewer inpatient and emergency department admissions. Another learning health system study found that once they implemented their learning health system, which was on lung cancer, that patients had a better or improved time to diagnosis and treatment. And then in another study, there was improved remission rates for patients after they created their learning health system. And so we have all of this evidence available to us around sort of what a learning health system is and what are the key concepts that should be a part of a learning health system. But we're still learning how we can actually apply this in practice and how do we actually move to a learning health system model. And so I'm just going to briefly touch on some of this. I know Brigitte is going to talk a little bit more about this in her presentation, but we are seeing more evidence now around some of these tools that can help us move into a learning health system model. So there's roadmaps available. So a study by Allen and others came out where they identified key kind of inputs, outputs, and outcomes that should be part of a learning health system and trying to guide researchers when they move to implement a learning health system model. The HIP Exchange has a database with different tools and toolkits related to learning health systems that can help other researchers move towards this idea or model of a learning health system. And then also some work that I've been involved with my team. We're looking at the specific implementation strategies that other learning health system researchers have used to transition their system to a learning health system so that we can better understand how to use some of those implementation strategies in our own healthcare setting or in other healthcare settings. And finally, I just wanted to share some of the current work that I've had the opportunity to be involved in Nova Scotia and the Maritimes. And I know there's lots of other work happening around learning health systems. So this is not a finite list of everything that's going on, but just some of the work that I've been able to be involved with. So in August 2020, there was some work that took place at the IWK where they were exploring how the IWK sort of functioned or didn't function as a learning health system using COVID-19 as a case study. So during that wave one of the pandemic, kind of what were the assets and gaps around how the IWK was able to rapidly integrate evidence into practice with that learning health system framework in mind. And then in November 2020, the MSSU Working Group on Learning Health Systems was established. So this work is for all the Maritimes who are kind of working towards this common goal of moving towards a learning health system. So this group is made up of patient partners, of knowledge translation experts, of researchers, where we all have a common goal of trying to collaborate and work towards this learning health system concept across the Maritimes. And then in September 2021, this is when I started my fellowship, which is a Canadian funded fellowship, which really puts an embedded scientist into a health system. And so this helps this idea of bringing evidence and research into practice more quickly, because learning health systems is a Canadian strategic priority of the Canadian Institute of Health Research. And so having this fellowship and different fellows across Canada working within different health systems is part of their approach to working towards that bigger learning health system goal. And then in December of 2021, I mentioned that review that I'm working on with my colleagues, which is looking at sort of the implementation of learning health systems and trying to understand some of the strategies and outcomes and impacts of learning health systems around the world. And then currently, there's some work being done at the IWK where we're looking at the patient safety program and really trying to move this patient safety program into a learning health system model. So this is just some of the work that's taking place in Nova Scotia and around the Maritimes related to learning health systems. And I just wanted to acknowledge some different people and organizations that support this work that I've shared with you today. So my fellowship supervisors are Janet Curran, Christine Cassidy, Doug Sinclair, and Annette Elliott-Rose, who are either embedded in Dalhousie or at the IWK and are really advocating and supporting this learning health system work. And then in terms of organizations, the MSSU and Learning Health System Working Group, IWK and Dalhousie, so these institutions are all helping to work towards this learning health system body of research. And then finally, in terms of funding, I just wanted to acknowledge CIHR as well as the IWK's Translating Research into Care grant, which helped to support some of this work. Thank you, and I look forward to questions later.
Thank you so much, Mari. I really appreciate listening to you present about learning health systems because I think it can be a complicated topic that you do an excellent job of just really introducing. So thanks so much. So before I turn it over to Brigitte, I just wanted to check if people could just turn off their microphones if they haven't already by pressing the mute button in the bottom left-hand corner. Thanks. So yeah, Brigitte, I will turn it over to you.
Thank you, and everyone just bear with me with all these screens open. I'm trying to, if I can just get a confirmation when you see.
We can see it, Brigitte.
You can see it full screen?
Not full screen yet. There you go.
Okay, perfect. Thank you so much for this invitation and to the flexibility of the MSSU team to allow us to push back this interesting topic. When Scott first reached out, we were right dead in the middle of the 5th wave. So I was like, there's no way I can turn around, but I'm really happy there was flexibility. And I think we're all in a better mindset right now to be able to learn a bit more about learning health systems. So still on the learning curve. I think the title is quite appropriate and really touches how the experience of learning health systems has been for Vitalité Health Network. And it is an ever evolving strategy because we needed to adapt in real time with this thing COVID that popped up a couple of years ago. And I think we learned a lot about all of that. So I think it's a good topic, a good title and I think it's important that we stay on that learning curve when you want to be a learning health system. So I need to cover some of the bases. What is Vitalité? We're one of 2 health authorities in New Brunswick, 2 regional health authorities that provide and manage care and services in an area that covers northern and southeastern New Brunswick. We're unique in the sense that we're the only francophone managed organization of this kind, and we have over 60 points of services, 7,500 part-time and full-time employees, 550 physicians, including 241 specialists, volunteers, pretty significant operating budget. So you can imagine the complexity of this organization, this network organization that we are attempting to run to the service of our population. I'd be remiss if I didn't take the time to put you in the mindset of the context in which we were trying to build this, because before even thinking of becoming a learning health organization, we were met with the challenge of becoming an academic health organization. In New Brunswick, I think we're maybe at the toddler phase when we compare ourselves to other provinces and other academic health centers. This has been growing, and we've been growing the ecosystem in our province significantly in the past few years. But initially, we have to understand that all the establishments in Vitalité Health Network did not have any university affiliations, and their primary end goal was to deliver care. And it was actually a known thing that if you came to practice in New Brunswick as a physician, well, you know what, you didn't have to do research, or you didn't need to have to do training. You could come and focus on your clinical work. And I think that was great for a point in time and period, but again, things evolving. Just to give you a bit of a history, in 1998, and that new building wasn't there at that point, but we did have the creation of a research institute that is now the Atlantic Cancer Research Institute, which was very much discovery-based fundamental research that was being conducted there. But it was the beginning of this ecosystem for us within the Moncton area, but especially within our health authority. In 2006, we had our first delocalized medical training program. So again, the reality of our weaker academic affiliations really came to the fact that we didn't have any medical training programs within our province. So in 2006, the first delocalized medical training program from Université de Sherbrooke opened its doors in Moncton, was followed not too many years after that with Dalmed in St. John. But this again speaks to the idea that it was a culture that needed to be developed. And with that came an affiliation with the University of Sherbrooke, but also an official affiliation with the University of Moncton that led to the actual designation of our university hospital center that was given to us by the Department of Health in 2010. So starting from, I think, needed to create that context to understand how, as an organization, we came about this idea of becoming a learning health system. So as you can imagine, the research ecosystem, research capacity within the organization was building, but at a slower pace. So it was only for the first time in our organization strategic plan in 2017 that we actually had a strategic direction aimed at building research capacity. So that to us was a big step in the right direction, but we finally had leadership for our organization that saw the importance of having this capacity within our organization. That led to us to create, at that point, I was director of research and training, and that led to the development of an action plan for capacity development. So I'm just summarizing quickly the different steps, but I need to put the emphasis on the fact that we really did take a lot of time doing an environmental scan of what other academic health centers look like. We did an extensive internal consultation process. We also then solicited expert content review from external reviewers and internal reviewers before we actually came up with a plan that we presented to senior leadership and board of directors for our organization. So to say that we really worked hard on getting buy-in for everyone, and to make sure that we had also alignment at a leadership, the highest leadership level, as to what we wanted to move forward to as an organization. Key findings of our consultation process, and we weren't surprised about what we heard when it came specifically about research capacity. There was definitely a need to build culture. There was a need to find resources, to have resources to develop this culture, whether it be human resources, financing, and support. So people with scientific expertise to help build capacity for mentorship. So these were all key elements that came out of our consultation process. And this wasn't unique to us as an organization. I'm showing this publication that came out of the Northern Ontario School of Medicine, where they described specifically what we were going through as an organization of when community hospitals, or even in our case, regional hospitals, become an academic health center and what's needed there. But what came out even stronger in our consultation process was the fact of how fragmented our system was. So I like showing this figure that depicts the US health system, but honestly, we could probably be fairly much comparable in Canada when we think of how services are hard to navigate. Everything is in silos. And at a presentation, actually someone mistook this slide as a new ride for Disney parks. So just to show the complexity of what a health system can look like. But when we talked to people on the ground, to physicians, to senior management, lower management, healthcare professionals, how people felt disconnected, not engaged. They felt that the patient was lost in all of this, that we were very far from patient-centered care that everyone tries to push forward. And that there was this urgent need to find a way to rebuild this engagement with the organization. So let alone trying to build a culture or capacity around research, we needed to build engagement towards Vitalité as a network. And that's been described in literature, and it brings me to the fact that we need to take a bit of time to realize that the regionalization of health systems has had an impact across the country. So every health system in the country has regionalized to some extent. And in New Brunswick, we've gone from 17 regional health authorities to 8. And then in 2008 had the major one where we became 2 health authorities. So you can understand how this can contribute to the identity and engagement of staff. So initially we belonged to a specific hospital. Now we're part of a greater network. What does it mean? So this came out to us as an important finding in our consultation process, and something that we really needed to take into account if we wanted to build a solid action plan to develop research capacity. So like I said, we really sensed that change was needed urgently. And how do we capitalize on this need for change? So we realized that a good action plan definitely had to include strategies to integrate the academic mission into the cultural identity of the organization. So we saw it as an opportunity to leverage our action plan to actually push a culture shift in our organization and create a clear objective for everyone to align with and to have a sense of belonging and engagement to. We needed, of course, to ensure that adequate resources, financial infrastructure, and human were readily available. And we definitely needed greater alignment with our academic and research partners. But a successful action plan, and I like my little fish there in a little spaceship, and I know some of my colleagues are going to laugh because I use this slide a lot, but our plan absolutely needed to, if we wanted to have buy-in from everyone in our organization, it had to be patient-centered, for the patient, with the patient. We needed to engage physicians. We know physicians are an important part of the system, but they're actually a central part of the system when you want to lead change. They need to be involved. They need to believe in what you're trying to do. They need to see the direct benefit to their patients. And that was a key element that we needed to take into consideration when thinking of this capacity building plan. And we had to find a way to use evaluation, research, and innovation to solve important problems that are relevant to the system. Problems that are in the system, not on the system. And that meant that we had to look at research and evaluation differently. We always think of research in a silo where scientists and intelligent people come up with great ideas that can then be translated into practice. And then we can, as a health system, say that we do evidence-based medicine. But if we really wanted to engage people in this action plan, we needed to demystify research. We needed to make research accessible. We needed to make it seen as something that could help them. So we actually had to shift the idea that research is only upstream, but can actually be used downstream, and where practice and patients can inform research. So it's clear that you can see the alignment between all of that and a learning health system. So for us, and I'm not going to go over what Dr. Somerville really went through very extensively and adequately, but the learning healthcare system model for us represented the optimal model or the approach to try to use and build research capacity within our system. To us, it was a way to make research accessible and to use research differently and in a meaningful way for our system. So again, this idea of what a learning health system is that research influences practice, but practice also influences research. So not minimizing the impact of patients and what patients can bring to the table, and use patient and the patient encounter experience as a catalyst for change. So to have all of this set up, Dr. Somerville explains some key elements that were necessary to ensure that, to enable or facilitate the creation of a learning health system, and is to have some sort of socio-technical infrastructure that helps support the concept. So for us, we were very inspired by the Alberta Health Services model of strategic clinical networks. And the idea was to create our version, which we called learning clinical units. And learning clinical units can be summarized as a strategy that is used to create a community of experts. So basically it's something, we create an opportunity for people to sit around a table and talk. But this community of experts brings together patients, physicians, policymakers, researchers, and community to help address health gaps. So it's talking about health problems throughout the whole continuum of care for a certain health theme, and to identify gaps and priorities that we all want to work on, that is important to everyone. And that's a significant, that's the key element. That's the key to engagement, basically, is to work on something that everyone believes is important. Their LCUs are guided by empirical and scientific evidence, the patient experience, clinical expertise, and not to minimize the network's strategic priorities. Because we talked about how resources are necessary to support research capacity. We're in a small province. We all know that we're not probably yet achieving the highest capacity of funding from the big funding organizations in the country research-wise. Accessing resources are not easy and difficult, and it's a very competitive environment. So by aligning with the network's priorities, we could sort of piggyback and maybe find projects and initiatives that we can combine and then sort of become self-financed through the fact that they become a priority for the organization. So learning clinical units, the objective is to bring administrators, which their clear objective is to ensure the best level of care. The clinicians want to treat patients to the best of their ability, and scientists, they want to generate knowledge. And then you bring the patient into the circle of experts, and you have an opportunity to engage and coordinate patient health experts and partners with the goal of improving the health of New Brunswickers by co-developing solutions to transform the health system. I'm sorry. When I get tired and take in French and speak in English, it's not always easy. So I might be blubbering a bit. Hopefully you can still follow. So to establish all of this, we built a governance and infrastructure to support all of this. So we had a steering committee that was really members of the highest levels of leadership. So the CEO, key VP positions, key directors, academic partners. So the idea was to talk about this and to have it ingrained at the highest level of the organization. And then the LCUs have their core committees that work through a shared leadership model. So they're co-led by a physician and a clinical administrator, patients, have scientists, researchers in the field around the table, and then other relevant partners that appeal to the theme that we're working on. And from there on, the goal of the core committee, so steering is oversight and approval. The core committee would look at gap and identification and prioritization. And then from identifying the problems they wanted to work on, we would develop working groups that work on the implementation and identification of evidence-based solutions, and then the implementation. And then these working groups would shift into an implementation group framework where we would include research and evaluation support to measure the outcomes of the solutions that we're putting into place. This slide, I'm not going to ask you to try to read it. The goal is not for you to actually see it, but it was really a key to the success of us launching this initiative is we had to align. And we had our process performance people work with us to look at all the levels of planning, financial, budget, strategic plans, equipment budgets, all the cycles, looking at the different financial quarters that the health authority had to go through. So having a good understanding of how, as a health authority, we prioritize what we work on. We needed to have a clear understanding of that to then fit in the learning clinical units in that world. And that really for us was a key element of success. And to be able to time meetings, time decisions, to be able to propose them at the right time, to be sure that we're included in budget planning. So all of that was very much an important element for us operationalizing LCUs. It's quite simple how the LCUs work. I gave you an oversight of the different levels of the groups, but the core committee and the working groups really do the brunt of the work. And the idea is that they identify gaps, so important problems for everyone around the table, engaging everyone around those priorities to have everyone focused on working on the priorities that are important for everyone. Identifying solutions that are evidence-based, looking at best practices, looking within our system, are we addressing this gap well somewhere? Can we scale and spread this solution? Can we evaluate it to see if it has impact and then bring it to other areas of the system? Small scale implementation of solutions. So really trying to scope down so we could launch initiatives locally and then look at measuring success and then evaluating and being able to then translate knowledge and integrate that knowledge and scale and spread the solutions. So this cycle, it shows a half cycle, but this idea is this continuous learning cycle that would keep going on and on and on. That was the objective. It is still the objective, but I guess it brings me to this timeline where I'm just showing you how we went about this. So we started the engagement and preparing change phase in 2018, early 2018. So I can't minimize the amounts of meetings and discussions and different levels of interactions with different levels of the organization and partners to build the momentum for this. We had a 2-day launch workshop at the fall of 2019. And then that led to the launching of our first LCU, which was focused on seniors' health. Then early 2020, we launched our second and third LCUs, which were based on surgical care and respiratory health. And then we all know what hit in 2020. So that brought about an opportunity for us to take a step back and do a formative evaluation of our LCUs and the implementation process up to that point, and to allow us to better align what a version 2.0 would look like, because we knew we were going to have to readjust post-pandemic for multiple reasons that I'm going to go through quickly. Briefly, the formative evaluation results, and we did this with an external researcher from the University of Moncton, Dr. Claire Johnson, found the key findings that people that participated in the initial 3 LCUs were generally satisfied with their experience. They really appreciated the multidisciplinary approach and the presence of researchers on the teams. I think that was very enlightening for many people. The pandemic, however, came up as it inhibited the momentum, and all were worried of how we were going to regain this momentum post-pandemic with staff and resource shortages. So our gut feeling that, we're going to have to rethink this strategy was not far off when we saw the results of our formative evaluation. So how do we recreate and maintain the momentum? How do we reduce the burden? Because we know post-pandemic, I'm talking too fast saying that now, but we know that our resources, the people on the ground, the people we want to work to change, build this change of culture with, are tired, they're stressed, they're overworked, and they could easily see this as an additional burden to have to deal with. So how do we bypass that? How do we create a momentum? So I tried to bring COVID in this discussion because I think it taught us a lot of things. It taught us the importance of healthcare organizations having the ability to mobilize and quickly react to an ever-evolving health crisis. So we all know how we had to be on top of everything all the time. We had to rapidly implement new best practices based on research findings from across the globe. And that was research being conducted in real time with COVID patients. we had to transform at lightning speed. And I'm not exaggerating when saying lightning speed, because that's sure how it felt that way. But we had to ensure that the health and safety of patients was the priority. And that was only possible if we could rapidly disseminate and integrate new knowledge that was being generated through research on COVID patients in real time. And as an organization, having the ability to actually generate new knowledge in real time through research and evaluation conducted at the point of care of patients affected by COVID-19. So thank God this was happening, that systems across the world were able to do this. And I'm saying that in the sense that I don't think Canada took its share or active or did as much as it could have. And I think it speaks to the fact that we're lacking a bit of infrastructure and foresight on what becoming a learning health system would allow us to be. So again, if the COVID pandemic taught us anything, it's to become a learning health system, and that has to be a priority. And touching to the fact of the Canada's performance with regards to the pandemic management and worldwide, there was a publication in January of early last year called "Integrating Research into Clinical Practices: Challenges and Solutions for Canada," and really it did depict that we didn't do our share of what we could have done as a country, considering the expertise and the knowledge that we have. And we seriously needed, as a country and as a system, to have a discussion that seeks to address the scientific deficit that prevails within Canadian health systems and its consequences, and that it's long overdue. Better healthcare depends on evidence-informed decision-making, and therefore on high-quality clinical research responsive to the system's needs. So having research integrated into the health system, a learning health system. We actually wrote a letter when our health minister was doing a consultation process early last year for developing the health plan. And as a health authority, we contributed to that consultation process and we proposed solutions. And I think we're getting some leeway and gaining some momentum with our government officials. But to become a learning health learning system, we need to strengthen health research infrastructure within the systems to facilitate the conduct of research in our establishments. We need to hire health researchers and health research professionals that are embedded within our system. So partnerships are important. We need to collaborate with our academic partners, but we really need to have that brain power within our organizations too. That's going to be crucial to bridge the chasm between health research and healthcare. Allow us to bridge that gap of discovery to actual application. We need to increase collaboration, again, like I said, with our academic and research partners. We have to sell ourselves as health systems that we're living labs, and we can serve as living labs to academics and researchers to help them develop new research questions and allow us to grow and innovate by the wealth and knowledge of their new ideas. We need to find a way to establish a sustained health research infrastructure. And that has to happen by the recruitment of highly qualified researchers and research professionals. And then we have to recognize the time and effort that's put into health research by clinicians and healthcare professionals. A lot of this is done voluntarily at this time, and that needs to be recognized in some shape or form. So next steps for us as a system, like I said, we needed to rethink how we're going to deploy the learning clinical unit approach. And what we've come down to as next steps is we're actually going to look at a systemic deployment of the LCU concept. Recently, the performance planning and quality portfolios were merged to the university mission portfolio. And that was a very strategic decision from our leadership and our CEO. And I think it's to see that continuous improvement that's fueled by evidence and that leads to higher quality, and building that momentum by having these sectors work together closely, and to bring the learning approach at the operational planning level and the strategic planning level throughout the organization. So bring this approach of functioning as an LCU, but actually as an approach as we function in managing in the managing of our healthcare system. So we want to transition towards learning clinical programs and having programs, for example, seniors health that are co-led regionally and that involve patients at the decision table. So making it the way that the health authority works versus adding in a new committee or a new structure. And beyond the health system, we're actually working on the concept of learning health communities. So bringing the approach of learning health systems into communities. So acting as influencers and supporters of developing solutions to healthcare needs and gaps in the communities, and giving them support to build evidence-based programming and to measure the outcomes of these programming, of this different programming, and seeing the impacts and helping them develop and grow and scale and spread. So we want to act as guides for our communities, and this is a way for us to meaningfully engage with our communities and having them around the table to plan and develop the care that they need. So this is something for us that is at the forefront of our community engagement strategy for the network, and we're bringing the learning approach to that. And that is all for me. Thank you very much for the invitation, for the opportunity to discuss.
Thank you so much, Brigitte. It's really incredible to hear about all the things Vitalité is doing. And thanks so much for sharing your wisdom with us. So we're going to start the question period. So feel free to put your question in the chat or put your name in the chat if you want to ask your question out loud, and I'll go through them in order. So the first question we have here was any of the work on COVID-19 and learning health systems published in peer-reviewed literature or gray literature?
This is referring to the study I mentioned. So that work is under review right now in a journal, so we're just waiting to hear back. But that work was actually sort of split into a couple different papers. So one is specifically looking at the caregiver and patient perspectives of how COVID-19 was handled during the pandemic. And the one that's under review right now is related to that, really looking at like the assets and gaps around how well the IWK functioned as a learning health system during that first wave. So hopefully it'll be published and available soon.
Thanks, Mari. We have another question here for Brigitte. What process did you use to select the priority areas or problems you worked on?
Okay, I'm not on mute. I was trying to see if I thought I was muted. We use different tools, actually. The core committee, the exercise, first of all, we needed to sort of paint a picture of, let's say, seniors health. We did 2 levels of consultation. So our first gut feeling consultation. So we asked people around the table prior to actually meeting, what are your gut feelings about gaps in the continuum of care for seniors within our system? And once we received that information, we then attempted to validate or invalidate, I guess, the gut feelings by looking at internal data, external data, and comparing ourselves to benchmarks and standards, I guess, for different elements of within the country, and then brought all this information together to the discussion. And the discussions were led and facilitated with also project management and performance improvement people. So they brought in certain strategies to animate with the group. Some groups were very difficult, some were very easy. I would say the easiest groups were where patients were very vocal. You can't realize how quickly you align priorities when the patient starts talking. All of a sudden, physicians, decision makers, everyone stops and everyone listens to the patient. So that was actually enlightening to see, and it really brought about a prioritization process that was quick and easy. But for other themes like seniors health, where we have so many partners involved in the delivery of care and it's so complex, so it was really looking at scope, looking at the actual influence we have on the gap. Is it multifactorial? Does it involve multiple partners? You know, we really wanted success stories to gain momentum. So how do we scope what we want to work on, and the level of complexity being the just right amount of complexity, also defining that. So different tools, different discussions, different informations that were brought in, and also securing everyone in the idea that we had a parking lot where, you know, maybe it's not a priority today, but it's not going anywhere. We're putting it in the parking lot and it might become the next priority. But the idea was try to scope to gain momentum.
Thanks, Brigitte. Feel free to, folks, if they want to add questions in the chat there. I have a question for both of you, actually. I'm just curious if you could share a bit more about how you engaged patients in your project, Brigitte, with the clinical learning units, and Mari, maybe with your new patient safety program and adapting the LHS model.
I can start, or if that's okay with Mari. For us, it was, we went through our hospital's Partners of Patient Experience program to recruit patients and to be part of the core committee, and also to then translate into participation into the working groups. Again, the pandemic stalled a lot of those efforts, especially patient involvement, because we couldn't meet in person. We had patients that didn't necessarily have access to technology. This is all things that we're going to address in our version 2.0. But it was really we went through an existing process within our health authority, and we're able to do the onboarding and then guiding them through the process. So they're really part around of the table for the prioritizing, the identifying of the gaps, and then they were part of the co-creating of solutions and implementation.
Thanks, Brigitte.
And I could share some of my, I guess, experience with the patient safety program work that we're doing. So at the moment, the first part of that work will be looking at the patient safety program at the IWK and trying to understand sort of, do they align with the learning health system right now? Yes or no? So looking at those different core components, like, are patients engaged and how are they engaged? Are they using data to inform decisions? Is there a culture of safety? So that's kind of the first step before we then move to the next step, which would be slowly building that program to be a learning health system. So if we find that patients aren't really engaged in a meaningful way in that program, then we want to work towards doing that in using best approaches to do that as well. But interestingly, from the review that I'm working on, that was something that has come up, is that across the learning health systems that were included in the review, we looked at kind of the different learning health system features that they described in each of their learning health system, and engaging patients was definitely the least common feature that people described. So I do think there's maybe a gap in that around learning health systems, and there's probably a lot of work that could be done to better engage patients in that learning health system model. So yeah, so I guess right now we're not actively working towards engaging patients in the patient safety work, but depending what we find from that first assessment, it'll be kind of the next step of our work.
Thanks, Mari. Just seeing that we're getting close to 1 p.m., I just want to thank everyone for attending today. And thank you to Mari and Brigitte, especially for your really informative and amazing presentations. I just want to let everyone know that I'll be sending out an email with an evaluation, and also I'll share the video of today's webinar with everyone as well. So please fill out the evaluation and let us know what you think. And thanks so much for attending today. Have a great afternoon.